Good evening, everyone. My name is Kevin Bergerson, and I am the Patient Educations Program Senior Coordinator for the Colon Cancer Alliance. And on behalf of the Certified Patient Navigators and the entire patient support team from the Colon Cancer Alliance, I would like to welcome you to tonight's webinar, Colon Cancer Under 50, latest update on the numbers, sponsored by UC Irvine Health. This is the 11th installment of the Conversations About Colon Cancer webinar series, which we here at the Colon Cancer Alliance have created to provide attendees with the opportunity to link with national experts in the colorectal cancer field together in an interactive online setting. This evening, we will be covering recent research findings that indicate that colorectal cancer is rising among young adults. While the cause of this rise is unknown, it's important to recognize that the changing pattern of this disease in our population is occurring. That being said, it's important to remember that the overall risk for colorectal cancer in those under 50 is still quite low compared to that of older individuals. It's important to understand that in order to improve prompt recognition and early detection of colorectal cancer, awareness of these changing trends among both patients and healthcare providers is needed. We will touch on the lack of information on the biologic mechanisms involved in young onset colorectal cancer, as well as how colorectal cancer in the young differ from colorectal cancer in older populations. In addition, we will touch on how more research is needed to better understand how best to identify high-risk individuals for screening, as well as how to avoid delaying diagnosis of colorectal cancer among young adults. Through additional research, we can substantially improve the outcomes in young adults with cancer. Before we introduce this evening's speaker, I just wanted to let all of you know that about this time tomorrow, all of you in attendance will receive a follow-up email with a link to a feedback survey about this webinar. We value your opinion and would be greatly appreciative to hear your honest feedback on how we can make delivery of our webinars better, and we would be greatly interested in hearing any ideas on any future topics you may have. Please look for that email tomorrow, and we'd be very appreciative if you could take our online survey and let us know your opinions. Thank you in advance for your help. Also, quick note about questions for our webinar. Our webinars are intended to be interactive, with attendees can pose questions via the GoToWebinar server for our presenter to cover. After our speaker has finished presenting, we may be able to address a few of your questions as posed during the webinar. Please note that we will be accepting questions posted online using the webinar control panel. To submit a question for consideration, click on the small plus sign located next to the word questions on the webinar control panel located on the right side of your screens. Then type in your question and hit enter. To get the most out of the webinar, we strongly encourage you to ask questions, and all questions not already addressed during the presentation will be posed to our presenter on a speak time available basis after the PowerPoint. If we run out of time, please note we will collect the questions and get back to you and follow up after the webinar. So accept our apologies in advance if we don't get to your particular question. As a reminder, our webinar presenters are willing to answer your questions to the best of their ability, but please remember, our presenters are here to inform you only, and any specific questions regarding your individualized treatment should always be discussed with your personal clinician and healthcare teams. And with that, we'll introduce our speaker. Our presenter this evening is Dr. Jason Zell. Dr. Zell is a hematology-oncology specialist who focuses on the prevention and treatment of colon and other gastrointestinal cancers at UC Irvine Chow Family Comprehensive Cancer Center. He is board certified in internal medicine, hematology, and medical oncology, and has received extramural research funding from the National Institutes of Health to perform genetic epidemiology-based colorectal cancer research, and is principal investigator or co-investigator on several NIH-funded phase 2 clinical trials involving patients with gastrointestinal malignancies. Within SWOG, a clinical trials organization in the National Clinic Trials Network, Dr. Zell is the Cancer Control and Prevention Liaison to the Gastrointestinal Committee. Additionally, he is National Principal Investigator for S0820, a large multi-center randomized phase 3 trial involving risk reduction among resected colon cancer patients, which is supported by the NIH National Cancer Institute Division of Cancer Prevention and conducted by SWOG. Dr. Zell received his medical degree from Nova Southeastern University, Fort Lauderdale, Florida, and completed his internal medicine residency training and hematology-oncology fellowship at University of California, Irvine via the American Board of Internal Medicine Research Pathway. And with that, I'm going to turn the webinar over to you, Dr. Zell. Welcome, and take it away, Dr. Zell.
Okay, thank you, Kevin. Thank you for the gracious introduction, and also I want to take this opportunity to thank the Colon Cancer Alliance, also for the staff here at UC Irvine for helping to put together this webinar. I hope it's informative. It looks like we have a good turnout, so that speaks to the interest in this topic, and hopefully we'll be able to clarify some issues and answer any questions you have. We're going to be talking about colon cancer under age 50. This is an overview of today's talk. We're going to talk about colon cancer in general first. I'd like to start by defining epidemiology. A lot of what we're talking about really is epidemiology. And that's the study of risk factors for a disease or distribution or spread of disease. So here we're focused on colon cancer, risk factors, and also its spread in the population. We're also going to talk about disease formation, which the medical term is pathogenesis, and then we will briefly cover the current screening recommendations. I think it's important that we set that as a starting point to launch into the discussion of colon cancer in young adults. At that point, I'll discuss the changing disease distribution or epidemiology, also clinical presentation, how it differs in young adults, and also clinical outcomes, how those differ in young adults. And then lastly, I will touch on future research directions. One of the important things about studying colon cancer is we can separate the risk factors into two types. Those risk factors that we cannot change, those we're born with, we call those intrinsic risk factors, and those that can be modified, extrinsic risk factors. So, for example, on the left side of this slide are the things we can avoid are age, our personal history, family history, and some predisposing factors, including the major inherited syndromes, FAP and Lynch syndrome, or HNPCC. We'll talk briefly about those today. But very interestingly, for colon cancer, compared to, I would say more so than many other solid tumor types, is the effect of modifiable risk factors. These can be very important. So things such as diet, red meat, processed meat, we know cause cancer, as does certain cooking methods. Physical inactivity is associated with increased risk of colon cancer, and separate from that, so is obesity. The other ones listed have a much lower effect on colon cancer, but there is risk associated with those factors too. And here is the incidence patterns for major tumor types in the U.S. I want you to focus on the blue line, and that really shows that there's good news here. Colorectal cancer has been on the decline since 1985, both in men and in women. That's in large part due to screening practices. And along with this decline, we have also seen a decline in mortality from the disease. And that is attributed also to screening practices because we can identify pre-malignant lesions, pre-cancer, such as a colon adenoma, and remove it before it turns into cancer, or at least detect it at an earlier stage when it's easier to obtain a cure. So, of course, treatment advances also contribute to the improved mortality rates. Now, colorectal cancer is not one entity. It's really, it can be thought of as being combined of different types. So there is a sporadic type, that's the most common. That's the kind that we see in approximately 65% of patients, but also a very strong familial influence for this disease, so that approximately 25% of patients have some family member with colorectal cancer. Now that's different from these rare syndromes and also the genetic syndromes, FAP and HNPCC, where they have clearly identified genetic predisposition for colorectal cancer. The familial influence is much less well defined, but we know it's important. So we think of colorectal cancer divided into these categories. Now, each of these groups, of course, has a different risk of colorectal cancer. So here is showing you the incidence by each of these types of genetic conditions: familial adenomatous polyposis, or FAP, H and PCC. Obviously, they're at much greater risk than the general population, as shown in this slide. And so the screening recommendations that I'm going to be discussing today and whatnot are actually not relevant to those higher risk cohorts. They have separate recommendations for people with these genetic conditions. And we're mostly focusing on sporadic colon cancer. But as you'll see in some of the literature, it's impossible to dissect in many of these studies which group that patients fall into. So we have to keep that in mind. Now, this is my only gross slide of the presentation, I promise. This is the carcinogenesis model. And one of the other important things about colon cancer, I mentioned the risk factors, which we can divide into intrinsic and extrinsic, or modifiable, but also we have this well-defined sequence of events that has been characterized in patients with colon cancer. So you can follow this in animal models, but also in people, where you have a normal colon epithelium that develops into an adenoma by a series of genetic events, and then through more into cancer and ultimately metastasis. And the reason this is important is because it can help us to target prevention strategies. And of course, this is where colonoscopy and the other tests, FIT test and Cologuard, which we'll be discussing, come into play. Because as these precancerous lesions bleed or are detected on an endoscopy, they can be then treated for cure. So this is a brief summary of the 2012 guidelines for screening of average risk individuals, so the average population. And as you see at the top, beginning at age 50, both men and women at average risk should use one of the following. And they're listed here. Most common is, of course, the colonoscopy or the FIT test or the new stool test or fecal occult blood test. The barium enema is not done anymore, and these guidelines are due to be updated, and it's rumored that they will do away with that one. But for now, it's still an accepted modality. Many institutions don't do the procedure. So this is what we have. Of course, this is not going to be of use to anybody under the age of 50, and the reason for that will be explained further in the next couple of slides. Now, nobody likes having a colonoscopy. Very few people volunteer to do a colonoscopy when they don't need one. And that's part of the problem here. Number one, we likely don't have enough endoscopists in the U.S. to do colonoscopies on all eligible patients at age 50. But there's a larger problem, which is that many patients prefer not to have the colorectal cancer screening test, which is the best that we have, due to their own preference or due to other reasons perhaps. It's estimated that depending on where you live, 50 to 60% of people that should be screened are actually being screened, and this is in the over 50 group. So there's been a lot of interest in developing less invasive testing or testing that would appeal to a broader pool of patients. And along those lines, we have the virtual colonoscopy, which is, it's really a three-dimensional CT scan. The advantage is there's no procedure, really no invasive procedure. But the disadvantage is if they find something, then you need the colonoscopy anyway to go back and take it out. So it's two procedures, and the prep is the same. So you would have to do the prep each time, and the prep is terrible. Many patients say it's worse than the colonoscopy itself. So with that, we move down the line. We have fecal immunochemical testing, which has been fantastic. It's a relatively, or I should say, very cost-effective technique to identify human blood in the stool. This contrasts with the prior stool test that we had just 10 years ago, which would be confused by patients who had a red meat meal prior to the test. This is very specific for human blood, and so it's come into favor as a preferred testing method. It stacks up very well against colonoscopy in the initial studies. However, long-term outcomes based on how well this does at preventing mortality are still not available. There's also the new multi-target stool DNA testing, or Cologuard. This requires a larger stool sample. You can see in the picture the kit that comes with it. But the same idea that we can look in the stool itself for any evidence of cancer. This looks at DNA, but also for human blood. It's a combination of those. So there are colonoscopy alternatives available. Now I want to turn our attention to colon cancer in young adults. So colon cancer in young adults is different from those in patients over the age of 50. It's different in terms of its incidence, so we'll talk about that. It's different in terms of the symptoms that you associate with the disease, and it also has different survival outcomes. There's other unique challenges, access to care being one of them, that are really unique to this population. So we're going to go through these in the following slides. The first thing to remember is that this is an uncommon condition in patients under age 50. In the graph shown to the right, compared to older adults, the risk of colon cancer or the incidence of colon cancer is very low. And that's what really drives the screening recommendation. So you can see in the graph here, at about age 50, the rates start to go up quite a bit. And because of that reason, multiple guidelines have instituted screening for colonoscopy at the age of 50. And so that it's definitely an important slide to remember. If you're wondering why we don't do colonoscopies on everybody from birth or whatever, well, this is how it started. It's because the disease is something that is more likely to occur the older you get. Now, we had interest in this ourselves here at UC Irvine, and my study team wanted to delve deeper into the issue. There have been a number of reports suggesting that under age 50, colon cancer is on the rise. And beyond that, my patients that are under age 50 will tell you on these online communities and whatnot, they know it's on the rise. So it was really a pretty simple task for us just to look at it. What we wanted to do is break it down a little bit better by race and ethnicity, also by specific age group, because under age 50 is a huge group. And so we looked at 10-year intervals, 20-year-old, 30-year-olds, 40-year-olds, etc. And California is a large state. We have 30-some million residents here. In California, cancer is a reportable condition, so all cases of cancer must be reported to the California Cancer Registry. We have access to the database, and we looked at 231,000 cases of colorectal cancer during this 22-year period. From that, we identified 5,617 young adults aged 20 to 39, and that is the definition, the accepted definition for a young adult when we're in the, at least in the field of oncology, anybody 39 and younger. We then took a look at the age-specific incidence rates as they differed by race, ethnicity, gender, and then location across the colon and rectum. And we reported the biannual percent change. So how much is the incidence changing over a 2-year period? Because we wanted to look at the change in incidence over time. And this slide starts a series of results, which basically I've divided into the good, the bad, and the ugly. So here we go. The good news is this. The absolute incidence of colorectal cancer is very low among young adults between age 20 to 29 and 30 to 39 years. So to give you some examples, in Hispanic and African American females in the 20-year-old age group, their risk is about 0.7 for 100,000 population. So for 1 million people, you would imagine 7 patients. And it's up to 5 per 100,000 among Asian Pacific Islander males in the age 30 to 39-year-old group. And that was the highest incidence in our study. So if you compare that to 70 to 79-year-old males in this study, there's 235 cases per 100,000 population. So obviously, It's what I showed a couple of slides ago, that the risk is low, and this is what is known, and I think it's good news overall. Now, this is the bad news. When we look at colorectal cancer incidence across all these different subgroups, the only groups with increasing rates of colorectal cancer are those under 50. So, for example, you can see where I've drawn the hyphenated red line to show in males and females the under 50 and over 50 group. And so over 50 is the screened population, and under 50 is the unscreened population. In the population over age 50, you see every 2 years there's a 1 to 7% decline in incidence for males, and a 1.4 to about 6% decrease or decline in incidence of colorectal cancer among females. So this is what I showed you early on with the blue lines in the national study. Colorectal cancer is on the decrease, and everyone believes that's because of screening. However, in the unscreened population, which is individuals under age 50, this is the only group where we're seeing an increase. And so the numbers are shown there. Those numbers may or may not strike you, but the fact that they're going up, not down, definitely grabs people's attention. And this is the ugly. Beyond those modest percentages that I showed you previously, if you look in certain subgroups, and these are groups you would never really think about as being high risk for colorectal cancer, at least we are not taught that in medical school. For example, a 20 to 29-year-old Hispanic female with left-sided colon cancer, and by the way, left-sided, those are the easiest to detect because they're close to the colonoscope. They bleed very readily and easy to detect blood in the stool from patients with left-sided colon cancer. They have almost a 16% increased risk of colon cancer every 2 years across the 22-year study. So it's really striking. And you look at these other percentages too. These numbers really caught our attention. Now, we are not the only ones to show this trend. Our paper was published in December of 2014, and the following month, January 2015, George Chang and his group at MD Anderson published this paper. It's very data heavy, but I would like to just summarize. They showed the same effect that we do. Each of these lines is showing the declining rates of colorectal cancer, and the first graph here is for local stage colon cancer. And you can see the lines look essentially flat, but they're declining a little bit. Only in the 20 to 34-year-olds do you see the curve of that line going upwards. And if you look at panel B here, you see the same trend for regional stage disease. These would be lymph node positive or deep tumor invasion, patients with that subset of colorectal cancer. Again, it's the only group where colorectal cancer is on the rise. And finally, for metastatic disease, you see a sharp rise here in George Chang's study. Now, what Dr. Chang did in the following figure was to show what's going to happen over the next couple of decades at these rates. And you can see it's really the young group, age 20 to 34 and 35 to 49, that we will observe at these current rates. If these current patterns persist, we're going to be seeing significant increases in the risk of colorectal cancer. So that's basically where we're at in terms of the risk and the changing epidemiology or disease distribution for colorectal cancer. But I want to talk about some of the other issues here. Symptoms. Classic symptoms for colorectal cancer are constipation, weight loss, blood in the stool, iron deficiency anemia, and abdominal pain. Not everyone has those symptoms, but these are the classic symptoms. Interestingly, and I guess it could be predicted because young patients are not screened, 94% of young adults have symptoms at the time of diagnosis. So their symptoms are bringing them in. In a screened population, you would hope that they don't have symptoms. Obviously, you're trying to detect a colon cancer before it's causing symptoms. And compared with older adults, one study, which I've referenced in Cancer from last year, showed that young adults with colorectal cancer on treatment had more pain, more fatigue, more nausea, more distress, drowsiness, rash, and symptom interference with general activity, including mood, work, relations with others, and enjoyment in life. And that's not something we had really recognized before that study was published. So there is some differences in the symptomatology that young patients with colorectal cancer experience compared to older populations. Now, when we look at family history, that's critically important in the young. And again, we have to be thinking about the genetic syndromes and also the familial type of colorectal cancer. Well, historically, it's reported that 20% of young adults with colorectal cancer do have a family history. So what does that mean? It means that 80% of them do not have a family history of colorectal cancer. In other words, we cannot rely on family history alone to identify young patients at risk for colorectal cancer. And another recent study at MD Anderson, which the reference again is provided there, and Nancy Yu is on this study team, they showed that 32% of patients under the age of 35 did have a hereditary syndrome, and many of these people were not suspected to, so they really had to look for it. 19% of these patients with the hereditary syndrome had no family history of colorectal cancer. So I think the point of this slide is to show you that family history is important. It's certainly not sufficient to direct who should be screened and who should not be screened. Well, I should say if a genetic syndrome is there, of course those patients will be screened. But in the absence of that, some of these issues come to play. Now, tumor characteristics. There was a United States SEER study. SEER is it's kind of like the California Cancer Registry, but across the U.S. they select key areas, and it's supposed to be reflective of the nation as a whole. Well, in a SEER study of non-metastatic colorectal cancer patients under age 40 versus over age 40, there were significant differences between the two groups. So young adults were found to have a higher tumor grade. There was a greater proportion that had the mucinous or signet ring type, and also they were more likely to have a higher tumor stage of diagnosis. They're also to have a higher lymph node ratio. So these things are all adverse prognostic features. Basically, they're predictors of a more aggressive type of disease, and yet that's what we saw more commonly in the young adults. In our own study at UC Irvine, here's a slide just to show the same type of thing regarding tumor stage. If you look in the 80-year-olds on the right of this slide, in a perfect world, if everybody adhered to screening, we would only detect local colon cancer. There would be no distant colon cancer or even regional cancer. But you can see if compared to the younger adults here, much more of the 50, 60, 70, 80-year-olds are diagnosed with local colon cancer. And unfortunately, many of the 20-year-olds and 30-year-olds and even 40-year-olds were diagnosed with later stage disease at the time of presentation. And we know that tumor stage diagnosis is a great predictor of outcome, survival. Well, it's not all bad news. Everything I've said there is certainly concerning, but despite everything I just told you, similar survival rates are noticed for individuals under age 40 versus those older. And you would expect with the higher risk features that young adults would do poor, but they don't. They're more likely to receive aggressive chemotherapy stage by stage, and that could even occur with minimal gain. There's a recent study showing that. And if you look after operation, there's improved post-surgical outcomes for young patients with colorectal cancer versus older adults. So this is the silver lining, that young adults do well, despite some of the adverse features that are associated with cancer, colon cancer in young adults. They do well. Now, there's other things that are quite different from older adults in the young population. So, for example, I've referenced some important papers on this slide that discuss these issues. Access to care is one. It has been reported that there's a reluctance of young adults to seek medical care. If you're familiar with the adolescent young adult oncology realm, people talk about the gap in healthcare from the transition of a child in pediatric oncology to an adult oncology setting. There is this gap period where people may fall through the cracks, and so certainly young adults fit right into that group, and there is some issue about either lack of insurance or other factors that may lead to this. But the lack of insurance is certainly concerning. I've given some numbers here just to show what that percentage can be. 25% without insurance versus 5% in the older cohort. And there's a lack of an appreciation of the rising incidence of colorectal cancer in young adults. I think very few people know about this, except for, of course, patients and their families. And I'm including in that physicians, which we'll talk about next. There's not a lot of awareness in the realm of primary care, although there's a lot of effort directed at that. So as you saw in one of my slides, some of the groups at greatest risk were those with the left-sided tumors in the rectum or in the distal colon, for example, sigmoid or descending colon. Well, those are highly amenable to screening by endoscopy or other methods. So that's also the silver lining here. We should be able to promptly make a diagnosis in patients that present with a left-sided cancer. All right. Well, there is some controversy right now, and I'm sure there's likely to be a lot of opinions about this just among those of us here on the webinar. I want to just set out some definitions real quick because it helps to understand the controversy. The natural question is, why aren't we screening below age 50? Well, screening means that we direct our efforts at healthy average risk populations. A 25-year-old that has rectal bleeding that comes in to your office, of course you're going to order a workup. That may include colonoscopy. That is not screening. That is early detection. And this is really where the effort has been, making sure we have prompt early detection among young adults. And I will note to you that there's numerous guidelines for colonoscopy screening. None endorse screening under the age of 50 for average risk individuals. The AGA, they will recommend for African Americans to screen at age 45, but nobody is recommending screening below that for any group. So because of that and because of the trends, there is some controversy right now on this very topic. Now, moving forward, what's the mechanism? We don't know. Perhaps it's the same genetics at play, perhaps it's not. In the familial cases, of course, it is due to the genetics, and that we have a better grasp of. But at this point, I'd have to say we need a lot more research. We do not know the answer. To that end, the Colon Cancer Alliance is pairing up with the American Association for Cancer Research right now to fund additional research on this exact issue to help us understand the mechanism for why colorectal cancer is on the rise in young adults. But I will point you to our recent meeting. Every year, 30,000 oncologists meet in June in Chicago at our annual meeting called ASCO, American Society of Clinical Oncology. And at that meeting, there's two really interesting abstracts published involving small numbers of patients. But I think it's giving a glimpse at the future where we're sequencing tumors from patients that are young versus older patients and trying to get a grip on what is different about the tumors themselves, and also to do thorough genetic analysis of young patients. So certainly there's an area where we need to direct more effort, and that's going to come through additional research support, and there is a big push for that right now. Now, Dennis Onnen wrote a paper here titled A Call to Action, and I think it sums up some really important sentiments. So, we need increased awareness among primary care physicians about this issue. We need to be thinking about risk modification and targeted screening, or even prophylactic surgery for young adults with hereditary syndromes. And then with average risk young adults, when they present with colorectal cancer-like symptoms, immediate endoscopic workup can expedite the diagnosis. So naturally, early screening in high-risk individuals, if we can identify high-risk individuals, perhaps through genetics or other mechanisms, and also through diagnostic workups in symptomatic young adults, those will ultimately improve young-onset colorectal cancer trends. So with that, I'm going to conclude with this summary. Once again, colon cancer is a significant health burden in the U.S., although the risk is low in the young adult population. The reason we're talking about it is because this is the only group where colorectal cancer is on the rise. This is something that is, the slogan is, it's very much preventable, treatable, and beatable. So the rising incidence definitely causes attention, even though overall incidence is low. Awareness of these changing trends, I think it's very important among patients and among healthcare providers to help us to improve outcomes. If people really in their 20s and 30s have symptoms of rectal bleeding and ignore them because they think it's impossible to have colorectal cancer, that is a real mistake. And so awareness can help in that regard. And lastly, we certainly need a lot more research to understand how best to identify high-risk individuals for screening and how to avoid the delay in diagnosis among young adults. So with that, I'm going to conclude and take any questions.
All right. Thank you very much, Dr. Zell. Just hearing those numbers, the under 50 numbers spelled out in such a concise way is both scary and fascinating. Thank you. At this time, we will be asking Dr. Zell to respond to a few questions as posed by some of our attendees during the webinar. As a reminder, if you have a question and have not submitted one yet, now is the time to do so. Click the small plus sign next to the word questions on the right side of your screens, type your question in and hit enter. And as a reminder, it's best to ask specific questions regarding your treatment to your personal clinician and healthcare teams. And with that, our first question comes to us from Carrie. Carrie, Dr. Zell, would like to know, why is stage 4 colon cancer so apt to return post-remission compared to other stage 4 cancers?
That's a great question. Well, first of all, stage 3C colon cancer is also very likely to return. The French told us in the 90s that stage 4 colon cancer could be cured, and in the U.S. we were slow to believe that. But the truth is, yes, stage 4 colon cancer can be cured. It requires aggressive treatment and typically surgery to the metastatic sites, be it in the lung or liver or wherever the tumor may go, or through high-PEC, let's say, heated intraperitoneal chemotherapy, which some of you, I'm sure, have heard of. So had you considered that question even 15, 20 years ago, people wouldn't understand the question. They would say quite simply that stage 4 is incurable and it just goes into remission and relapse, remission and relapse. Now we know that's not true. Patients can be cured, but certainly remain at a very high risk of recurrence. And if you think about it, once a tumor is spread to one site, well, how did it get there? It had to spread from the colon into the lymph nodes, out into the blood vessels, out to the liver, through the heart, to the lungs, back through the rest of the body. And it could have taken root anywhere. And so occasionally you will see in a stage 4 patients, you've treated them for cure, and then another tumor may pop up in another location. So that's really the reason behind it. Having said that, I will say, and that's really the role of foundations like the Colon Cancer Alliance, there is a strong community of stage 4 colon cancer survivors, and I know there's great interest by the Colon Cancer Alliance in helping bring together patients that were diagnosed initially with stage 4, because we have long-term survivors, and they have unique risk also, not just from the disease, but just from the treatment, the amount of treatment that they've received, and the different types of treatment they've received. So there's certainly a lot more interest in survivorship among stage 4 colon cancer patients now than there was at any time previously.
Okay, Dr. Zell, we got a couple real quick answer questions regarding age of screening, and then we have some more complex questions that are coming up here. Phil has asked, as a colorectal cancer patient diagnosed at age 40, what age should his children have a colonoscopy?
The first question, of course, which he can just consider on his own for privacy rules, has he been checked for a genetic syndrome? We need to rule that out first. And I'm just going to assume, for the purpose of this question, that he does not have one of these genetic syndromes. If that's the case, then this is sporadic cancer, and the age of screening is 10 years younger than the age that he was diagnosed. So at the latest, his children should be screened at age 30.
Okay.
It's much younger. If he has a genetic syndrome, then it's much younger.
And we have a similar question from Yasmin, who wants to know what the testing age is for African Americans. Is it still 45?
It is 45, but to be honest, there is discrepancy across the different guidelines, so it creates some confusion. USPSTF, that's the big one, United States Preventive Service Task Force, I don't believe they specify anything for anyone below 50. The American Gastroenterology Association, AGA, they do acknowledge, and so does the internal medicine one, the ACP, the American College of Physicians. They acknowledge that African Americans have a higher risk and should be screened or offered screening at age 45. So there's not 100% agreement. I know that's something that's frustrating to all patients. It's just as frustrating to all doctors that these societies don't all agree on their recommendations. But most people would accept African Americans that they should be screened earlier, and age 45 is the most commonly accepted number.
Thank you, Dr. Zell. Next question comes from Peg. Is there any different recommendations to detect signet ring cell colon cancer?
No, there are not. We don't have, for example, the Cologuard test is the multi-target DNA testing. That doesn't tell you which type it is. I mean, that would be the closest one to have a chance to do that because it's looking at different DNA signatures. But no, there's no screening test to identify that. It is very interesting that signet ring type colon cancer it's a more aggressive type, more common in young adults, and certainly we'd like to know more about that. But to be honest, we are nowhere near being able to screen for that preferentially over other types. In the end, it doesn't matter. We would like to prevent colon cancer. And so if you can identify a premalignant cancer that would become signet cell, well, that can be treated for cure very easily, and signet cell cancer would never arise.
Interesting. Next question comes to us from Marion. Would like to know, are young adult cancers intrinsically more aggressive, or is it simply due to their later discovery, the lack of screening, and therefore discovered later and after a longer time to advance?
Well, that's the problem. It's as you can see from some of the slides, the advanced features at diagnosis, some of those are due to the fact that this is an unscreened population to begin with. And so yes, the poor outcomes are directly associated with that. Things like stage, for example, are the number one predictor of outcome or survival. And in an unscreened population, you would expect stage to be higher, and that's exactly what we see. So I do think, I would like to say it's as simple as yes, the aggressive nature of this disease is all because the cancers have more aggressive features at diagnosis. But then again, in the studies that compare young adults to older adults, young adults do better, or they do the same, I should say, in terms of their outcome. If you look, if you could account for all these differences, they would be doing better, but they have more aggressive features, and yet they do the same as the older adult population. It does remind me of pediatric oncology a little bit, where Of course, childhood leukemia is cured at a higher rate than adult leukemia. And in general, leukemias, lymphomas in pediatric populations, you do see something like this too. But for whatever reason, and maybe it's because young adults tolerate treatment better, they're more active and whatnot, we don't know any of those answers. And that would be really fertile ground for research.
Are you aware of any research studies that have been conducted that have looked into lifestyle choices that impact colorectal incidence among the under 50 crowd?
Yeah, I'm glad you asked that. That's a very interesting topic. Epidemiologists are interested in that. For example, obesity is linked to colorectal cancer. With every generation in the U.S., the rates of obesity go up. And could obesity alone account for this excess risk that we're seeing in young adults? I'm not sure, but it certainly could be, and we don't have a good answer about that. The other thing is diet. Diets change over the course of history, even within California, where we did our study, or within the U.S. Diets change over time, and it is possible that we're missing some environmental triggers that are causing this. But to this point, I don't know of any high-quality research to indicate what it is that's causing these trends.
Thank you, Dr. Zell, and thanks to Army for that last question. And Tom has asked, why do you think colorectal cancer is on the rise in the under 50 crowd, the younger generation? Is it, do you think it's more genetic, or phenotypical?
I think it's, my disclosure is that I have a joint appointment between medicine and epidemiology, so I think about risk factors quite a lot, and genetics. But for the type of differences that we're seeing here, it's always a combination, like the Greeks said, between nature and nurture, between genetics and then the environment. And I do wonder a lot about the environment, because genetics, it takes a longer time for genetics to change in a population. And the environment changes in many ways constantly. So I do think about that. I do think about physical activity, lifestyle, obesity, diet. And the reason why I suspect those things is because colon cancer, more than most solid tumor types, has these modifiable risk factors associated with it. And so you have to think that there's a role for risk reduction if we could identify particularly which of those factors were responsible for the rise.
Interesting. It's interesting you're mentioning, risk reduction. Laura would like to know, are there any strategies you would recommend for increasing awareness of young onset colorectal cancer in the public and primary care and other healthcare physicians? And are any of those strategies enacted at present?
Well, I think we're doing it right now, to be honest, and that's really the role for foundations and for patients and patient advocates and patient families, in addition to physicians. Physicians' reach is not as broad as the collective reach of patients and their families. There's 1.2 million colon cancer survivors in the U.S. right now, and of course, they're very interested in prevention. And those that are under the age of 50 are very interested in this issue about screening. And so I think it's going to take a large effort involving the public, not just medical professionals. And I think working through your foundation is a great way to start.
Got a question here from Mitch. He would like to know, do you think one possible explanation for the increasing rates of colorectal cancer in young adults is the degradation of the standard American diet and the propensity of adults to rely on fast, convenient, and cheap processed foods?
Well, we know, that's a great question. So I will tell you, risk of colon cancer is directly linked to processed meats more than it is just for red meat. Okay, so that we know for sure. But if you look at colon cancer survivors, the same things that are associated with risk of colon cancer in the first place actually correlate with their outcome. So we published a study on this in 2007, and in the same year, the Harvard group published a very similar study showing that in colon cancer survivors, their diet impacted their survival from colon cancer. So people who ate a diet high in meat, fat, and sweets did poorly, and they were not having heart attacks. Okay, that wasn't the endpoint of the study. They looked at all causes of death, but even time to colon cancer recurrence or death from colon cancer was also shorter if patients were eating this Western dietary pattern. And so both prior to cancer and then after a diagnosis of cancer, diet does definitely play a role in colorectal cancer prevention. And so, yeah, I think that there has to be a role in the changing diet for this disease in particular. And we don't see that for every disease. Colon cancer, high glycemic index has been associated. There's a number of dietary factors. Everything we eat does pass through the gut, so logically you would think there could be an effect. But I think that's a good point.
Okay, I got a next question here. We got just like three or four more minutes for a few more questions. Next question comes in from Dawn. In your opinion, what should we do as patients to raise awareness in the medical communities? Since this new data seems to be slow in getting out to primary care physicians, should we be reaching out to our previous clinicians who misdiagnosed our disease? Are there other programs in the work to educate the medical community about young onset colorectal cancer? And just by the way, she wants to let you know that you're her favorite oncologist.
Well, that's a very hard question to answer, but thank you for the question and the comment. It's a great question, and I would say, of course, there's a lot of guilt among not just patients and their families about why weren't we diagnosed earlier, also among doctors, primary care doctors and whatnot, that whether or not they're at fault, it's something that nobody wants to see. Nobody wants their young patient to be diagnosed with colon cancer. I can tell you that for sure. I think approaching them directly with this information would, I can't think of a graceful way to do that, and it might be rather difficult. And I'm not sure how much of a lasting impact that would have on the public or even the health profession. Now, reaching out to societies, I will tell you, a colon cancer survivor, particularly a young colon cancer survivor or their family members, have a very powerful voice. And so I know the online communities are strong. There's a lot of kind of grassroots effort to raise awareness on this issue. And so I think the answer is to keep on doing what you're doing. I think the Survivor Network has raised most of these issues. I'm a prevention researcher who focuses on prevention among people after they've been treated for their colon cancer. But the only reason I can do that is because the public raised so much awareness about the fact we need more prevention. And so research money is available for prevention among survivors. Well, same thing here. Among young adults, adolescents, and young adults, I think there does need to be more awareness also on a health policy level, and maybe that's kind of the next step. I can tell you if you ask to start screening with colonoscopy at a much younger age to one of your congressmen, they're not going to get very excited about that. But we have much easier and cheaper ways to screen too. So maybe some of these issues can be sorted out in the medical realm, but some can be sorted out on the health policy level too. Okay. And for that, there are societies and groups at the state level and also across the U.S. That can help individual patients get involved.
Sure. Very good, and they can certainly get involved with a wide variety of organizations that are out there in the colorectal cancer space. Colon Cancer Alliance is one of them. And last question for this evening before we wrap it up. We're getting a lot of questions we're not going to be able to get to, and I want to thank everybody for those questions. And but the last one for this evening is from Julia, who wants to know that colorectal cancer has been diagnosed in 3 generations of her family, and she has looked for a genetic test but has been unable to find a geneticist to test her. She is an African American woman and would like to know how would she might find a genetics test. Where would she go, and how would she go about doing that?
Okay, that's a great question. And just for the audience here, there's the rule of thumb is there's a 3-2-1 rule for hereditary syndromes, so Lynch syndrome in particular. You have to have 3 family members. One person has to be under age 50, and you need to have these need to be first degree family members as well. So I don't know the rest of her history, but it's not that important. The fact that she's got 3 generations already makes you think about familial syndrome. There are centers of excellence for high-risk colon cancer. Most regions have that. I would refer her to one in her local area, and maybe also, Kevin, this might be something the Colon Cancer Alliance can do better. There are certain centers, and I can tell you, Lynch syndrome patients, FAP patients, they already know where these centers are. They seek them out because they know they're going to get good care at them. And so I think all of those will have a strong genetic counseling group. Now, genetic counselors are terrific, and they spend about an hour going through medical records. You can find them at most hospitals without having a high-risk clinic. And for starters, I think I would ask her to talk to her primary doctor, ask for a referral to a geneticist because of this issue. I think it's appropriate. And then the geneticist can trigger whether or not she needs genetic testing or not. So if you're at a center where they have excellence in high-risk patients, I would go there. But I really do think any geneticist, they're well equipped to get to the bottom of this and see if there is a genetic syndrome.
All right, very good. I'd like to thank everyone for all of their questions, but we're kind of out of time for this evening. On behalf of the Colon Cancer Alliance and all the attendees, I'd like to thank you, Dr. Zell, for your time this evening. I appreciate it, sir. Your expertise and time was greatly appreciated. Do you have any parting comments for our group this evening, Dr. Zell?
Well, thanks. I feel like I'm there with everybody. It's a lively group, and the webinar format, I think it's rather unique, but I hope it was educational for everybody, and I really appreciate your time.
That was very amazing. Thank you. And before we go, just would like to bring everybody's attention to some quick announcements. Don't forget to join the Never Too Young Coalition next month when they have a Never Too Young webinar called My Story Go Colon Cancer Before 50. That's going to be on October 5th. It's got an early start time, so please note of that. And I'd also like to point out that the Colon Cancer Alliance on Wednesday, October 21st, is going to have our 12th Conversations webinar series on EGFR inhibitors and rash management. Prevention is the key. Look for that, and registration opening soon at our website at ccalliance.org/webinars. And finally, don't forget the Colon Cancer Alliance's National Conference is heading west this year to the beautiful Sonoran Desert. Join the Colon Cancer Alliance in Phoenix, Arizona as we present the Live Your Best Life Conference on October 30-31. This is the Colon Cancer Alliance's signature patient support and outreach event. And this year, we will be featuring presentations from 16 national experts on the latest advances in colon cancer prevention, treatment, and survivorship. Join us and see what the buzz is all about in Phoenix this October, where we're expecting more than 250 people from all over the country to be in attendance. And we'd like to see you there. Register online at coloncancerconference.org. As a reminder, our survey will be coming out tomorrow. Please take a few minutes to complete that. We want to hear how we can make these better for you, and thank you in advance for helping us. Thank you, everyone, for attending, and we sincerely hope you enjoyed this webinar. As a reminder, this webinar has been recorded and will be available for viewing within a week of the broadcast at ccalliance.org/webinars. In addition, we'll be posting the top 5 takeaways and other related information, including some of the question and answers, to our blog the week following the webinar at ccalliance.org/blog. If you'd like to share any comments regarding the webinar, please forward your comments right to me at kbergerson@ccalliance.org. And on behalf of the Colon Cancer Alliance and tonight's presenter, I'd once again like to thank everyone for attending this webinar. I hope you found it informative and value-added. Good evening, and take care, everyone.